First, I'd like to thank everyone for being here. On behalf of the Endourology Society and the Focal Therapy Society, we'd like to welcome you to the latest installment of the Masterclass in Endourology. It's really been a wonderful educational initiative thus far, and we'd like to thank Varian Medical Systems for their grant and support of this educational activity today. So today promises to be a very interesting discussion on focal therapy. Specifically, we're going to be focusing on how to start a focal therapy program. And really, who better to discuss the intricacies of this topic than the all-star panel of thought leaders you see before you. And we're privileged to have them all with us today. Please do keep in mind that today's webinar, along with all previous and future sessions, are being recorded, and they're going to be available on the endourology.org website. Simply go ahead and select on the homepage, follow to the Education tab, and then select on Masterclass. For your reference, this is an overview of today's CME program that you can go back and look at your discretion. And here's a quick overview also of the agenda that our speakers will be going into today. So with regards to CME, you're going to go ahead and receive a survey from Michelle Paoli via email. What you want to go ahead and do is indicate which seminars you've attended during the previous calendar month, and then you'll have your CME certificate emailed to you. And please do make sure you fill out the evaluation questionnaires at the end of this and each seminar, as these are important for securing your CME credit. I do want to remind everyone that there is a Q&A function on your interface in front of you. We encourage you to participate, as our speakers will have an opportunity to answer your questions directly. Don't use the chat function. And of course, remember that all of this is being recorded, so if there's anything you missed, please do check back with our website to view this at a later date. So without further ado, I'll turn it over to Dr. Polascik.
I'd like to welcome everybody. As an introduction, the Focal Therapy Society was founded in 2019, and we're currently partnered with the Endourological Society. So we hope to bring you a lot of content in the next year regarding surveillance for prostate cancer, detection, different types of imaging modalities, and minimally invasive treatments using focal therapy. I'd like to introduce our first speaker, Dr. Art Rastenhad. He's currently the Vice Chair of Urology at Lenox Hospital, and he's the Northwell Health Systems Director for Prostate Cancer Therapies. He has a vast experience not only on the image-targeted treatment side, but also serves as a radiologist in interventional radiology. Dr. Rastenhad.
Thank you, Tom, for the introduction. I'd like to thank the Endourology Society for, of course, supporting the Focal Therapy Society, and it's my pleasure to be here today. The cornerstone of any good program, I'm going to try to go over the nuts and bolts to help everyone today. The secret sauce, everyone wants to know how we do it, and I'm going to tell you what the secret sauce is. There is none. It's just a lot of hard work and getting a great team to work with. Speaking of the teams, you really have to look at these components. Radiology is your primary area of focus because this is where the patients are going to come through. It really matters on what imaging is being obtained and how the quality of that imaging will impact your patient care. It's having your colleagues and partners convert over to an MRI-based screening program, and then choosing the modality for therapy. There's several choices out there. I'm not really getting into that today. I'm talking about the foundations and the nuts and bolts of the program. And having a focal therapy working group. You need to have a closed loop system for feedback so you can learn from your mistakes and learn from your successes on how to optimize your program. We've been saying this for years, but it is really garbage in is garbage, gets garbage out. And unfortunately, as I really try to highlight, imaging plays such a major role. If you're not involved with the imaging for your patients, you're going to have a difficult time selecting patients for focal therapy. Because if you have a poor quality MRI that underestimates or doesn't even visualize tumors, you may be treating a tumor and missing one in another area. And this does happen. And we really try to minimize this by having the strength of our team in our pathway as well as the quality of our imaging. As things have changed over time, we've gone digital to full digital. Digital biopsies and now to fusion biopsies today. There should be no more blind biopsies. This should not be happening. The AUA in October last year endorsed image first before biopsy, which really lends itself to building a focal therapy team. And what are the old triggers for biopsy? We know what they are. The elevated PSA and the nodule on exam, but that does not exist and it's no longer viable. You should be using risk calculators, imaging, and even biomarkers to select patients for biopsy. So we're shifting from a majority low-risk disease to intermediate and high-risk prostate cancers by using this pathway. And in that, we are detecting focal diseases that may be amenable to focal therapy. A lot's changed over the years since these two great mentors of mine, Brad Wood and Peter Pinto, as you guys all know. We had our first focal therapy meeting in 2008. And since then, the field has just exploded. And the first ever publication was almost 20 years ago using imaging for biopsy. And I think we've come a long way, but we have a long way to go. What is fusion? Well, every program is pretty much based on this, is the idea of overlapping the sensitivity and specificity of a high quality MRI with the ease and use of ultrasound in your office or in the OR to perform the biopsies. And this 3D data that we obtain, we can use later to select patients for focal therapy. I want to make sure everyone understands how fusion works because every technology is the same at this point. It uses surface rendering. That means all those little triangles on top of a prostate data set, which this could be an ultrasound or an MRI, is key. So if you have a poor quality MRI or you have poor segmentation on your ultrasound, you're changing these data sets and it's very hard to align to get this good co-registration. I'm going to dumb it down a little bit for just a graphic. If you look on the left side of the screen, you see two data sets, two squares that are not aligned. Then on the right where they are aligned, where you're using these small triangles and matching them because they're each unique to the surface rendering of both objects. Taking this one step further, a common pitfall I see in patients or in places when I go and visit is, are they including all the prostate on the segmentation on the MRI? That's the entire prostate. So commonly, you're going to see people only include the first part, this peripheral zone, and the central gland or transition zone, and leave out the anterior fibromuscular stroma I've shown in purple. You see that purple? That is key because on ultrasound, the interface between the edge of the prostate, the capsule, and the fat is really what helps shape the image data set for ultrasound. So if you imagine you left this out, every single time you do a procedure, this is not going to look like you're getting a good fit to your MRI model. Elastic warping. Now I put this image in here. Look at the upper right screen. Watch what's happened. There's a snap and you've just changed all that data. And I want you really to see this. Look at the upper right again. Watch that purple and green line. The green line's the ultrasound. The MRI gets squished into the ultrasound format that's been made. And that's the challenge here. And I think it's important to understand that I rarely use elastic warping because it alters the data set. And I want everyone to realize that. Because if you have an altered data set one day and then you do a treatment the next day, this could pose a challenge with focal therapy and targeting lesions. Again, the imaging is key. Sorry for my font changes. I moved to my work computer because of a faster connection. But 3T imaging, make sure you have the key sequences and the dedicated team I talked about. But guess what? Even if you don't know anything, if you just get your department or your imaging center to use the PIRAD's recommendations, that'll help elevate you to a quality MRI most places aren't even doing today. And that's a challenge we're dealing with every single day, especially with outside films. Now, I put this up here just as an opportunity for all you out there to take a look, and you don't have to be able to read an MRI, but these key facts will help you understand what good quality MRI can be. These are all T2 images on the left side of your screen, the 1, 2, and 3, and then the one in the middle. You don't have to have images like the one in the middle. That T2 image is the best I've ever seen. That's why I put it in the talk. But it's a person that's never had good wine wouldn't recognize it if you only drink bad wine. So at least now you know what an excellent picture can look like and compare that for your studies in the future. You should at least have some delineation between the peripheral zone and the central gland in your imaging. You should be able to see that, and some internal architecture. If you're missing this and it looks like this washed out image B, you know you have a problem. That's not going to be really helpful for focal therapy. The cool thing with these technologies, you can take data from your fusion biopsy and create 3D models for treatment. You can see the 3D model on the lower right-hand side of the screen that's moving around right now. The blue is the urethra, the green is the targeted ablation zone, and you can plan for these things. That's what is so exciting about moving forward focal today. And an example in the upper right is another picture when we look at what's the data available, how are we approaching this, and this is just an example of a biopsy or a treatment screen. Again, when you're treatment planning, it's nice to have these 3D pictures because when you do the procedure, you can see if the bone's going to be in the way because the pubic bone can limit you. So it's important when you set up your case, you understand how you can check yourself and help, and that'll really give you that opportunity to avoid the pitfalls and not be able to get the needle in where you want it to go. This is an example of a fusion screen of the information from a fusion biopsy is then used and planned to plan a cryoablation using 3D rendered ultrasound and 3D MRI data. The blue box in the top middle screen is the external urinary sphincter that I marked to hopefully avoid any damage to it during the treatment. And you can see the ice ball around the target as well as a margin. This is really important stuff, and this is what's available today for all of you users out there. To reinforce the idea, it's so important, the pathway. You're involved in every step of the pathway. This is a study that looked at the difference of two approaches, same radiologist, same magnets, and a fusion biopsy, but the doctor that did the fusion biopsy, one of them reviewed the MRI before the case and segmented themselves, and that worked out to a 238% increase in the detection of clinically significant prostate cancer when you control for all the other variables, PSA, gland size, target volume. So it's important to understand that you can have a real impact on your pathway. And if anyone offered you a 238% return on a stock investment, I bet you would take it. So I'm trying to reinforce these ideas that this does equate to some bottom line in building a program as well as your revenue streams, because if you were missing these opportunities to find patients, you're not going to be able to build a program. I like to, again, reiterate, there's no secret ingredients. What do we use with our MRI and our programs? The image review is key. You have to, understand the basics quality so you can speak to your radiologist. And again, I told you, use the PIRADS documentation. The PIRADS system was built, I'm not a huge fan. Everyone knows me that I get upset by what's in there, but it was the whole point of that document was to lift everyone to a basic level that we can grow from. It's a minimum standard, not a maximum standard. So I want you to understand that, but that's how it gives you a conversation tool with your radiologist to at least get the best scan out of your systems by having this conversation. And if they say, I don't really want to do it, it's going to take too long, you're like, well, the ACR says we should be doing this. So that really helps you. Number two, post-fusion biopsy review. Every case when I get done, I call the patients, I review the MRI, and this gives me an opportunity to see what went wrong, what went right, was there discordant path, and are they a candidate for focal therapy? And it also, I do a transperineal biopsies, a majority of them. It's a dry run. It gives you an opportunity that if this case was a focal case, are they away from critical structures? I showed you how to see the external sphincter and I marked it on the MRI, and that can help you learn where it is so you don't damage it. So transperineal biopsy approach is a great opportunity for a dry run. I do it with a stepper and a grid. I know other people do single point. I think the thing I would like to say to those people that do single puncture on the side, there's a certain amount of warping and you distort deform the prostate. So you're not actually in the same exact area because you're pushing the prostate down or up to line up the needle coming in. So it's difficult to have an accurate assessment of where those needles went on any of the fusion biopsy platforms because you're batting the prostate around to try to get to a specific area. The treatment planning, I really went over this. I talked about being involved in this. It's important for you and your radiologist to have a working arrangement. You need to have that support because unfortunately, if you don't have the experience in reading the MRI yourself, you're going to depend on someone else. And you should not get to the point where you're just treating a cartoon when you come to the fusion biopsy or the ablation using this fusion software. You need to understand what went into it to get to that point. I think it's super important, and it's helped me a lot over the years teaching myself and learning from my mistakes. Treatment follow-up, we all talk about this. It's really important that post-ablation imaging occurs. You have a follow-up biopsy schedule with tissue confirmation. And if you're doing a lot of focal therapy and you're interested, the Focal Therapy Society actually has a registry that we're going to be tracking cases going forward, and we're getting a lot of collaborators. And this is something you could be interested in. You could always reach out and contact us, and we have a group that is setting this up. It's actually one of the speakers today. Tom Polascik is kind of the president, or he is the president of the society, but Arvin George has been leading the push for the database integration, and Tom, Avi, and Arvin are really doing a great job pushing this forward. So that's really the end of my talk right here. But again, I just wanted to reiterate these key facts for you. And this is doable. And I wish you guys all the best. I want to say thank you for everyone to allowing me to speak today. It's my pleasure to share these talks. And I wish you all the best. Thank you.
So how many have done a cryoablation procedure in the office? The vast majority say no. This is a very new concept, and we'll hear from Dr. Bianco shortly of how he went about doing this. I think that in the future, some of these treatments need to translate to the office space. Number two, regarding starting a focal therapy program, it looks like the answer was, I have an interest but have not yet started. Hopefully this talk will get some of you started. We do have proctoring available, and we have a number of courses on how to read an MRI and do both fusion biopsy and as well as targeting for treatment. Number three, regarding resources at my center to perform focal therapy, the two most common answers is I have a solid foundation regarding fusion biopsy in place, which is excellent. You need it, as you heard from Dr. Rastenhead. And second, my patients are beginning to request focal therapy. We're only going to see this increase in the future. I'd like to introduce our next speaker, Dr. Arvin George. He's a friend of mine. As mentioned, he's now the chair of our newly launched Focal Therapy Society registry. I would welcome everyone to participate because we need this data going forward. Arvin is the head of focal therapy at the University of Michigan. Dr. George?
Great, thank you so much. And I'd like to thank Dr. Polascik and Dr. Rastenhead and the Focal Therapy Society for giving me the opportunity to speak, and also to the Endourological Society and specifically Michelle Paoli for helping organize the masterclass series and integrating some of the concepts of focal therapy into their program. So I've been tasked with sharing the first steps in terms of selecting a treatment modality when you're considering starting a program. And it looks like there's almost 40% of us out there, at least within this webinar, that are interested in starting a program and that have patients who are now asking about it. So what I'm going to talk about today, what are the key treatment considerations? What are the things that we're looking for in a technology when we're selecting our first ablative modality? I'll go briefly over the existing treatment modalities that are out there, both that are commercially available and that are also in process of development. And then briefly over patient selection by modality. So what are the things that we look for in a technology? What are the principles that we want, or what are the features of a technology that would be most useful, especially when starting out? So one is going to be patient selection and versatility. So if you look at this screen here with the images on the top of it, you can see there's a lesion in the midline closer to the apex. And then in the bottom, you can see the red arrow pointing to a lateral lesion at the apex, and then the membranous urethral, you can see the urethral sphincter lateral to that, pointing to the green arrow. So there are some technologies that would be able to tackle both. Some would be optimal for one versus the other. So for example, for cryoablation, your ice ball would likely have to freeze very close to the sphincter. And it would not necessarily be the best treatment choice for this patient. So the ability for your technology that you choose to be able to treat different patients with different tumor locations and different tumor characteristics is important. The next item, I think, is the learning curve for learning the technology. It's certainly the one initial concept is image-guided therapy in general and fusion, and that already is oftentimes a new skill set though it's becoming standard of care for many providers. But this adds an additional layer on top of it, and every technology has its own nuances. And so something, especially when you're starting out, that has a short learning curve would be important. Certainly cost, whether or not it is approved and you can get reimbursement for it, is going to be important to ensure that there's financial viability. And then also efficiency in terms of integrating it into your practice or workflow. And also procedure length, I think, is something that most of us consider as an important feature, given that we have busy schedules. And I know that Dr. Bianco will be giving a great talk on in-office cryo a little bit later. So what are the existing kind of commercially available technologies that have some sort of approval? So if we look at the ones in red are cryotherapy, HIFU, and radiotherapy. These have either a oncologic indication or a prostate-specific oncologic indication. So HIFU has a new, even though the FDA approval is for prostate tissue ablation, the new CPT code that goes live in January of 2021, it specifies essentially an oncologic indication. Irreversible erectroporation, laser, transurethral HIFU, these are all either prostate or soft tissue ablation, including microwave. So what are the new modalities that exist out there? And I'm naming a few of them there, and this is not an all-encompassing list, but just to bring it to the attention of our participants. We have a gold nanoparticle photothermal ablation, and the nanotherm device, which is injectable nanoparticles followed by a stimulation of these within a sort of an MR ball. There is a bipolar radiofrequency ablation, Revive, which is akin to the water vapor ablation, similar to Resume for BPH. Topsolicin, which is an injectable agent, photodynamic therapy, and even boiling and non-boiling histotripsy. So so how do you learn about all these technologies? Some of you who participated in the recent FOCO meeting know about this, but we do have, if you're interested in understanding what are these different technologies, you can go here and you have different representatives from each technology giving a short presentation on their specific technologies. So you can learn about all of them within an hour, essentially. So this is also just a general schematic in terms of how do you decide how to treat. And this is not exhaustive. This is just to frame it a little bit so that you can understand that different technologies have different strengths and different limitations. So for example, in the anterior gland, cryo is extremely safe. You can't necessarily orchestrate the exact shape of the ice ball, but anteriorly, there's very little things that you can damage, especially in a primary case. For large glands and anterior lesions, sometimes the beam will not be able to reach if you're using HIFU. Posteriorly, you're getting close to the rectum. Cryo can be used. All other technologies can also be used, but it gives you a little bit of pause because you are close to the rectum, and it's kind of, for people who have more experience, would be more comfortable treating closer to vital organs. HIFU gives you the opportunity to create very specific and small customizable ablation zones with a high degree of precision at the prostate capsule. And the apex is a challenge for all different focal therapy treatments, and certainly with the dosimetry being a science, radiation therapy would be potentially have a role in for apical tumors. Now, the bottom line is that the point I'm trying to get across is that there's no one size fits all, especially if you're an early user. And so either you pick a single technology and work within that technology's limitations and choose appropriate candidates, and then eventually layer in additional technologies as you gain more experience to expand the patient population that you can offer ablation to. So why didn't I include cancer control as one of the main considerations? And that's because there's really no difference in the ability of a technology to ablate tissue. We know that if you apply laser to tissue, it's going to destroy the tissue as long as it achieves the right temperature. Similar with HIFU, similar with cryotherapy, and we know that these technologies can destroy tissue. That's not the question. And really, there has not been a single technology that has taken pole position with regards to having a significant benefit with regards to oncologic outcome. Every single technology have unique mechanisms of failure, and oftentimes it's due to patient selection rather than the technology itself. As long as you work within the parameters of that technology, it should be entirely adequate to give a good oncologic treatment. Now, what do I mean by unique mechanisms of failure? So to give you an example, if you are treating a tumor that's close to the urethra, cryotherapy, which uses a warming catheter, you'll end up having a heat sink where the temperature may not get cold enough to deliver a lethal temperature to the tumor. If you think about HIFU, where as you create small little ablation zones, the gland can expand, and you could theoretically develop skip lesions or untreated areas between the ablation, between the small focal ablation volumes. So in terms of versatility and patient selection, these are one of the criteria I mentioned early on. There are different technologies that will be especially useful in primary versus salvage. So for example, if they have an indication, such as HIFU does in salvage currently, if you look at gland size, so sometimes the gland size can limit the use of a specific technology. The size of the lesion or the cancer volume. You can, if your absolute ablation volume or the area of each treatment is small, then treating large volumes of cancer can be a challenge for a specific technology. And certainly lesion location, like I pointed out in the first slide with those pictures, there are some technologies which will be more amenable or better suited to specific tumor locations within the gland. So also there's a learning curve to any new technology. And what does that learning curve consist of when we're talking about focal ablations? One is the treatment planning, and in some specific technologies, it can be complex. When you have small ablation zones, ensuring that there's overlap between your treatments, making sure that you have adequate coverage of not just the true lesion, but also the margin that you plan into it. And sometimes that is not automated and it has to be manually done, and it can be a challenge. Additionally, there are technical aspects of every single technology, so-called knobology if we're referring to ultrasound, but just understanding those technical aspects can be a chore in the beginning of when you're learning a new technology. So the simpler technology is I think easier if you want to become facile, especially early on when identifying a technology. And then afterwards comes the steps of refinement. After you understand the broad technical aspects of a technology, you start to realize what are the nuances of treatment. And certainly those technologies that are simple allow you to get to that refinement stage much more quickly. So what is a key consideration is going to be to ensure that there is financial viability of the technology that you use. It's got to be, in terms of cost, there's a cost of acquisition, and that's either to you, your hospital, your practice, and then there's a cost to the patient, and that makes a difference. If the cost of the patient is high, you're going to decrease the number of patients who are going to be eligible for a specific technology or treatment. If we look at FDA approval and reimbursement is often tied quite closely together, but it actually lets you know whether or not, one, it's financially viable, or second, if you even have access to that technology. The FDA has granted approval usually for a soft tissue ablation or prostate tissue ablation for most ablative technologies, rather than reserving the prostate cancer ablation for most technologies. Cryotherapy was historically grandfathered in, and that is why it is approved by the FDA, and it is also included in guidelines. If it is not specifically approved by the FDA, sometimes these technologies reach into guidelines by the pool of larger bodies of evidence that support its use, such as the use of HIFU in the salvage setting. And then there is reimbursement. So there are some technologies that are covered by insurance, and then some that are not, and they would be considered a non-covered benefit. And what that means is that if you're gonna offer a technology that is a non-covered benefit, that means that is going to be an out-of-pocket cost for the patient. And I know that there are people who are joining us from multiple different countries today, and oftentimes it may be, a non-covered benefit may be applicable to you as well. I don't think this is specific to the U.S. market or population. So when we think of acquisition costs, what do those entail? How do you even know what is it going to cost you to get started with a new technology? There are usually three different models. You can purchase it outright, you can lease it, and then you can do a per-click model. So purchase obviously will have the highest out-of-pocket capital cost to start with. But once you establish a high volume, your overall cost is low. With a lease, it's kind of a middle of the road cost, but you don't have to have a large amount of capital upfront. And then there's the per-click model. You are going to pay more per case. However, you take on less risk, because if you don't have the patients, if you don't have the volume, then you're not paying for the technology. And so when I started off, and even continually to this day, I personally use a per-click model that allows me to adapt to the market and the environment. We do accept a higher cost and a lower margin for this reason, starting out. So I mentioned the efficiency of the procedure and the procedure length. And one of the things is the consideration of what type of anesthesia is required, whether or not it's paralysis, or whether it's sedation, or if you can even do it under local anesthesia in the office, but like we'll hear about later. The ablation volume of each technology. So here you can see an example of isotherms for different cryotherapy needles. And this allows, if you can form a large ablation volume in a single treatment, it improves the efficiency of your procedure and reduces your treatment time. Ideally, in my opinion, you want that procedure time to be really 2 hours or less. Otherwise, it can become tedious and challenging to be able to maintain a high volume. And then finally is access. At the end of the day, you need to have an efficient way to access these new technologies, whether that means that you're able to get to a third-party vendor to be able to use it, or lease the device, or use it per click. There are some new technologies that are in the space that, for example, urologists may not always have access to treatments that are performed in bore, and that can be a little bit of a challenge. So you have to partner with a radiology or a hospital to integrate it. Even though these technologies are great, they can be barriers to access to a new technology. Now, when you're starting a new focal therapy practice, what do I think are the key tenets that you want to adhere to? I would say starting it out in an ASC or a hospital, because that limits your personal exposure or cost, and they can bill at a higher level, and so they can absorb a higher cost of procedure than you can in your own practice initially to start out. You want to contain your cost to ensure viability. Even in the beginning, it's easy to spend big just to make things easier, but you have to be considerate of this, because if this is going to be a long-term thing for your practice, then you want to make sure that you contain your costs early on. I would recommend a per-click model to start, and choosing a single technology. The most accessible, I would say, currently are going to be cryo or HIFU, or you can use both if you have access to it. But if you're going to choose a single one, make sure that you work just within the limitations of that technology for patient selection. And then finally, if you're looking for a patient population to start with, I think salvage candidates are going to be your lowest barrier. They oftentimes have limited treatment options with significant added morbidity of radical treatment options. And also you have a patient population who has a localized recurrence, usually or oftentimes to a single lobe of the prostate or a single location. And you don't have to worry about the other side, because it actually has already received a treatment if you're considering a patient who has biochemical recurrence after radiation. So they are an easy patient population to be able to offer this to. So I'd like to thank you again, and we'll be welcoming questions at the end. And I'll turn it over back to Dr. Polascik.
Thank you, Dr. George. Excellent presentation. I'd like to introduce our final speaker, Dr. Fernando Bianco. This gentleman is a thought leader and is really the first one to think out of the box and figured out how you can do cryotherapy in an office setting. He has a vast experience, and I think a lot of us feel that patients at some point are going to want to come to the office and be treated, and we need to figure out how to do these things in a more outpatient center. Dr. Bianco, looking forward to your talk.
Thank you, Tom. Thank you to Art and Arvin. Excellent talks. And really thank you very much for your kind words, Tom. I'm privileged to be presenting this data and doing this presentation today for the Focal Therapy Society. Those are my conflicts of interest, and without further ado, we'll continue with the talk. So where were we at the arrival of the millennium? And I think Art addressed this in the earlier of the talk. is that, focal therapy was just an inception. And like he said, the first meeting was in 2008. So back then, we were really looking at, by the time I was a resident and then a fellow, at the works that's being done in Scandinavian prostate cancer group. The pivotal trial were on the works, but we really depended on level 3 serious. Prostatectomy was for osteourologists like the way to go, most of them. And as to put it in an analogy, stealing this slide from my good friend Andrew Stevenson, open prostatectomy was like the market leader, and in this curve from Clayton Christensen, the Innovation Dilemma, basically open prostatectomy was the blockbuster in town. We were detecting more tumors, doing more surgeries, the techniques were being perfected. Little innovations were happening then. However, the real deal was the laparoscopic and eventual robotic movement that was starting, that was confronted with a skepticism. Yet it was initially done as more and more people started looking at. So what happens 20 years later? So we have now level 3 information from 3 randomized studies. And what was the message? The message from the Scandinavian Prostate Cancer Group, which was 81% of patients have palpable disease, so clearly not the ones we were detecting nowadays. There were no survival differences. The early cancer-specific survival differences that were observed, instead of getting wider, got shrinker over time. And the mean benefit over a 23-year period was about 2.9 years of life. If we go to the pivot trial with the most recent publication this year, 70% of death events, we could see that the surgery provided just a year average of gain in quantity of life. However, it imposed a 3 times greater risk of incontinence and a twice at least in erectile dysfunction, starting with a group that already had a high prevalence of erectile dysfunction. When we look at the PROTECT trial, again, that adds the arm of radiation, we see that there was no benefit so far in early findings in survival. And now, but the key there was that the active monitoring group, about 40% of them basically were converted into surgery and radiation. And that's a critical endpoint, because when we look at focal therapy, the conversion rate will be certainly one of the outcomes that we want to look at. So basically in the 2020s or late 2010s, this decade that's finishing, really radical prostatectomy for urologists has become the Netflix, depending on you have, and most of them are done robotics. I've done as well thousands of them. However, we know that it doesn't produce the results that we expected. And there are clear indications for it nowadays. If you're 55 with a PSA between 10 and 20, probably that's the call. Or if you're younger than 55 with at least in grade 2 or worse, then you should probably do that. And on the other hand, if you're older than 60 and at least in grade 1, you probably should not be doing that. You should consider surveillance or focal therapy. So in the current paradigm, it's a dichotomy. You either go black and white, and either you do whole gland treatment or you do no treatment. And I will contend that the reason why surveillance was done is because we couldn't find those tumors, we couldn't see those tumors, and basically we went ahead and to avoid harm, you basically observe these patients. And by doing so, you aim to preserve continence, erection, ejaculation. In other words, having better quality of life. And now we know that with radical treatment, the gain in life expectancy is not as much as we know, and the loss in quality of life is worse than we expected. So what's the case for partial gland ablation? I think that Art and Arvin put it well together. So to just say it succinctly, now with fusion on the hands, it's about preserving quality of life without burning any bridges. That's usually what I tell my patients. And why did we choose to go with cryo? Well, basically, the story is long, but in 2012, after Pivot came out, we were stunned with the results, and we started thinking a little bit different on how we could help patients. And MRI fusion devices were coming. And as we started doing this and we moved it to the office, we were able to develop this several steps that were discussed well by Art and Arvin today. One of the reasons that we chose cryo is because it was indeed labeled by the FDA for treatment of prostate cancer. And the reason why it was labeled is because it was a cold registry. Dr. Polascik is an ample contributor to the cold registry, where about a third of patients were treated focally. Now, it's not what we're doing now, because we're adding the whole layer of fusion that adds further safety, but there was a premise and there was data there that could show that this was effective and safe. So that's the local, so under local anesthesia brings this. So what are the origins really of them? And the origins were really some work done by our good friend Winston Barcells back in 2002, thinking about how to treat the prostate focally and starting at a good diagnosis with desaturation biopsies and segmenting the prostate and thinking in this view. However, Winston's basically preferred that to do 50 samples under local anesthesia was too much for patients to take. When we look at the literature, really, there's a paper by Hugo published back in 2009 addressing biopsies that show on a dual work that it could be tolerable and they were taking up to 26 samples. However, this had no traction. Another paper by Idris Mashvili published in the British Journal of Urology, 150 patients randomized to a pudendal versus a strict perineal block. And again, there was no traction afterwards. The problem here was with the pudendal block, they would have paresthesia for a couple of days. Patients didn't feel comfortable. There's another big study by Pepper and Aragona with 3,000 patients on transperineal biopsies. However, they went from local to spinal or general. So again, the whole thing didn't have any traction. As we work on this technique that we developed, we decided to, because of good advice from other friends, to go into the US Patent Office and really patent the method and patent our vision of where we thought this was going to move, if it was going to be successful. And one of the premises was using MRIs, not just to looking at the areas, but also looking at the probabilities that certain areas are going to have and of having cancer, and then addressing treatment to those areas so we can model that and eventually be more successful and control better whether a patient has success or not in avoiding harm. So as well covered by Art this morning, I mean, you could try to establish your own fusion program, what I call a super woman or super man phenomenon, in which you acquire the imaging, you interpret the imaging, you do the software processing, everything that Art expressed very well. You determine the area to be treated, and if you're in an academic setting, I think you get more likely to have success with these things. It requires a lot of teamwork, and Art stressed that in his lecture as well. And of course, it requires imaging. Like Art said, garbage in, garbage out. It's the same thing. If the images is not good, you go nowhere. The other model, however, which I think will be more easily to implement and much more inclusive to all urologists, not academics, but also the community, will be an outsource model where you outsource all this several steps like the acquisition, the imaging, planning, the software processing, and you just focus on what you do, which is basically understanding better the MRI, but you focus on the procedure. Whether it's a fusion biopsy and then a fusion treatment. So you focus on what, on the clinical principles and the data it's acquired. So, and this is critical, so you can know your results as well. So we started the program back in 2014, and we have been able to train over 24 urologists since. So this has gained traction. And, one of our good friends, Dr. De Bruin, was able to implement our technique of local block in the Andros clinics in the Netherlands. And also we started this with our friend Jim Hugh at Cornell. And we have done it with several other of our colleagues that have come and seen what we do. So the best way to understand what we're doing in our program is to start with a clinical case, a 64-year-old with a PSA around 8. He has adequate erections and he has a hypertension, etc. An MRI is ordered, and you see a PIRATS 3 that basically is shown in the screen. He goes into our program, which we registered at the clinicaltrials.gov, and it's approved by organization IRB, in which we establish it with the aim of having events. So the eligibility is ample. I would suggest that if you're going to start our focal therapy program nowadays, I will focus basically on what is in yellow, lesion grades 1s or 2s. And if they're 65 and older, 3s. And then with less than 50% of the prostate taken by tumor. The other critical element is the follow-up. These are the patients that require the closest follow-up of all. Basically, you don't want anybody falling through the cracks because the price is too hard to pay. So anyway, at 3 months, we get our first PSA, we get flow studies. Then we do the PSA often the first year. An MRI at a year is mandatory. And depending on the MR, and I'll show you some data why, we will consider a biopsy, MR and PSA dynamics. And if that is negative, then we follow them every 6 months, and we will do MRIs based on PSA dynamics or at fixed points, and then we'll do a biopsy if there's any abnormality on the MRI. This is how it gets done. So the superficial block starts really close to the anal verge, and then we go really from lateral to medially, kind of like dissecting that triangle. And we do that on the right and left side. And then we advance the transrectal probe. We like to use the stepper and a grid because that stabilizes. The patient is in lithotomy, and you're not really rubbing around the probe, which is one of the things that causes more discomfort. The grid allows us to be precise, to get into the place we want to be. Then we go with a periprostatic block, like it's being shown right here. We do again on the right and left side, respectively. And after this, we'll be ready to do the fusion. This is the MR with the already planned. So we plan everything ahead of time as we outsource it. And then basically, we do the segmentation of the ultrasound image on the fusion platform. And that fusion platform has on the background the MR with the entire plan. So after we have segmented the prostate, we start doing the co-registration, and it uses a sort of a deformable co-registration based on algorithms. And it adjusted the prostate as you go laterally, of course. And then you are ready to go into the sagittal view, where you're going to actually do the procedure. And here you can see how we're taking the biopsy in this patient on certain areas. It seems to have a PIRAT solution 4 at the apex anteriorly. And we just take samples from the suspicious areas, but we also take random samples. All right. And here you can see the precision, so we know exactly where they are. And the coordinates on the right-hand side allow us to know where they were positive. In this case, at least 3+4 and another core 3+3. This is the same patient now coming back about a month later for treatment. The block is essentially the same. We actually started doing the block on the cryoablations, and then we translated it to the biopsy. This procedure will be longer than a biopsy. A biopsy takes 20 minutes. The cryo takes us an average an hour. We will, and in this here, you can see again the mesh of the MR showing the treatment area that we want, the target that we picked up, and the actual cryo probes that we're going to use. So everything is already set up, so the urologist focuses on the treatment and how to get it done and supervise it in a safe way. That's the target area that we want to cover. We can see the outline of the prostate, the same fusion platform. And as we can see here, there are basically 3 cryoprobes that we're going to put. So we're putting right now a what we call a rod, a nice rod that creates a 4x2 lesion. In this patient, because the tumor is at the apex, really it's close to the sphincter, we put a thermocoupler. We do this based on the anatomy. I think that we can treat everything, anterior, posterior, apical tumors. You can do it safely. We don't use thermocouplers when we don't need them, but we use when we need it. And the same goes with the urethral warmers. When we don't need it, we don't use it. And that's roughly 90% of the time that we don't need it. So anyway, we're advancing the cryoprobes, as you can see it in the image. And once it's all said and done, we start the cryo process. And here's where fusion provides a lot of the advantages. The fact that we can see the outline of the prostate while it gets distorted because of the treatment based on the MR provides us with the safety measures that we need. We can even see the Foley here that's not getting affected by the ice ball. The patient, though, is going to be on a lithotomy position for close to 60 minutes, right? So usually, we use nitrous. We offer them nitrous if they want, so they can do this. Or sometimes they just fall asleep. Okay, in the beginning of the program, we use some Valium, but after we migrated to nitrous, that works better. But the local block itself, tremendously, we asked them what kind of music they want to listen, and some of the techs come and really chat with the patient throughout the procedure for security reasons. We didn't want to put the face of the patient or anything like that. But that's basically the 2 procedures at once. So what have we learned about this? This is this patient, again, 3 months later. His PSA dropped from about 7.9 to 1. His IPSS improved from 19 to 5. And you could see the flow rates before the treatment and after the treatment. So one of the advantages also is that we have improvements in urinary function. And I will show you how they get quantified. The erectile function was preserved. Right now, this technique that you saw, this procedure is being done in 3 cities across the United States. We have an experience of 800 patients with 935 procedures. So many patients have been treated for a second time. When we look at our series, we have done from focal to hemigland to whole gland, or what we call MR fusion target cryoablation or SMART TX, and that's 80% of our patients. In the cohort, less than 81% had a PSA less than 10, and 77% are tumors that are non-palpable. As you can see, one of the advantages with cryo is you can treat multiple lesions. We've done that 40% of the time, and most of our patients have been Gleason grade 1s and 2s, but about 25% have been Gleason 4+3 or worse. This shows the number of patients and the frequency in the columns and the pain that they describe by procedures. And essentially, you can see there the average procedure between 2 and 3, and the minutes is close to an hour. We did an analysis on side effects on 525 of these patients, and basically grade 1 complications or adverse events in 5% of the patients, most common being some hematuria, chemosis, that kind of thing. And grade 3, 5 patients, most of them, those are defined by requiring a CHIRP about a month after the treatment.
Fernando, we have to wrap it up. We have 30 seconds to wrap it, and then we have to.
So going, the PSA response, 75% is the delta. And you can see here that the biopsy rates about 35% at a 1-year positive biopsies, but most of them, 80% are clinically insignificant. The conversion rates are very small in both cohorts. And as we have looked into what predicts having a positive biopsy after cryoablation, all of these factors have not. However, the MR using the PIRATs on those areas that were not treated is one of those things that can help us. So in general, the functional outcomes, there's no incontinence, no climacturia, 74% of patients have improvement in flow rates and transient ED. So what do I tell patients? I tell them that I'm confident the tumors will be destroyed, that we're not burning any bridges, that their quality of life will improve. And I stress them the cancer may come back, so surveillance is critical. So I think that at the virtue of this, linear focal therapy will be inclusive to all urologists, not exclusive, and it's the next disruptive innovation in our field. I want to thank you very much to all of the attendants, and especially Dr. Polascik for his invitation today.
Thank you. I'd like to thank all the speakers. These were very informative talks. I'd like to thank again the Endourological Society. You know, we've been working as a working group for the past 10 to 11 years, and the Endo Society has been very supportive of the idea of image-targeted ablation from the very onset. And right now, we're working with them to bring these educational presentations to you. I'd also like to thank our sponsor, Varian, and hopefully we'll have more focal therapy topics during 2021.
Fantastic. Thanks, Dr. Polascik and everyone. That was really great. Just as a reminder for everyone, the show continues next week. We have another webinar where we're going to be diving into robotic Resia-sparing prostatectomy. Again, a reminder, you can see on the bottom, go ahead and visit the endourology.org website in order to register for that class. Again, you can also rewatch, this webinar and all of our previous webinars there. For those who aren't members of the Endourology Society, I certainly encourage you to join. There's a host of benefits, including but not limited to full text access to all the Society's journals. Again, for more details, go ahead and visit the Society website. And finally, a not too early reminder to save the date for the World Congress of Endourology and Technology, which has been rescheduled for next September 2021, again in Hamburg, Germany. Thanks again for all joining. We'll see you next week.